It is my pleasure to sort of moderate this particular panel. In my travels around the state and around the nation, I find that the rural health systems and care are under attack, I think is probably a good way to phrase it. The resources are becoming ever more limited so that rural hospitals can function, but yet they serve a vital safety net for all of us. And if you were here yesterday, you saw the graphics that there are some counties that may not have people and they have cows, but where you have people, you may not have doctors. And I think our two panelists will address some of these issues. Our first panelist is Emily Briggs. She is actually the TMA, Texas Medical Association representative to TCHMB. She is a family medicine physician and certified in that specialty in New Braunfels. She is trained at the University of Texas Health Center in Houston. She has a master's in public health. She has been president of the TMA Como County Medical Society, and she's just completed serving 2 years as chief of staff at Christus St. Rosa Hospital in New Braunfels. She also has chaired the, I'm going to shorten it, the Perinatal Reproductive Committee at TMA. I like perinatal because it covers all of us. And is a force also on the council, Perinatal Advisory Council. Dr. Kimberly McKay is an obstetrician gynecologist trained at University of South Dakota. She's been working as a general obstetrician and gynecology from Arvera Medical Group, and she's recently become the clinical vice president of that group. And that group serves 14 hospitals over 72,000 square miles. So the panel will decide who's going to speak first. If any of the panel has slides, please let the projectionists know if they want to use them.
Well, good morning, everybody. I'm Emily Briggs, and it is amazing to sit in front of, or stand in front of all of you. Some of you I've been able to talk to newly with this conference, and others in past conferences or annual summits. And the breadth of awareness, of knowledge, and experience in this room is phenomenal. So thank you all for attending this week. Again, I'm Emily Briggs. I'm a family doc in New Braunfels. Rather than a rural facility, we are what I have termed micro-urban. That's not a real term, it's just something that I came up with. But that's because people think, oh, New Braunfels, I haven't heard that name, you must be rural. And I'm really not, I'm micro-urban. But that term doesn't exist outside of this room, so don't use it officially. So in my micro-urban city, town, area, we have two local facilities. They are both level 2s for neonatal care and are striving for level 2 for maternal care. So I'll talk about those in just a moment, but just to give a little bit of information for those of you that are brand new to this, which I don't think any of you really are, but that's okay, I'm going to give you some background information anyway. Why are we doing this? Why are we talking about rural facilities once again? You've already seen many slides on this over the last couple of days, and the Institute for Healthcare Improvement has come up quite a bit, and so I'm going to reference them as well. They have identified rural health challenges, and so one of them is the geographic distance and transportation issues. In an Illinois project, Chicago actually, they had difficulty with transportation, and so they did a pilot project where they provided Lyft accounts to each of their participants, and that got them to their facility in the very urban area of Chicago, but they still, in that very urban area, couldn't make it to health care, and so they provided Lyft accounts. We have also heard, even here yesterday, about telemedicine in order to improve that access to care when it comes to geographic distance or transportation issues. Another thing that's been brought up is economic instability, which of course is worse for our racial and ethnic minorities, and so that's something that the IHI has identified as a challenge. Social stigma and privacy concerns. So, in a small town, everybody knows everybody's business. So maybe I'm not going to obtain that care because then my doctor goes to my church and they might share stuff with my brother or my cousin, and so I'm just not going to go and get that care. So not only do we have these other challenges of transportation, geographic issues, but also those social concerns as well. Skills maintenance of any provider with low volumes in the rural setting is another challenge that was identified. We must insist on providing safe and high-quality maternal care in all settings and all volumes. So these rural facilities need that high-quality care just as much as our urban facilities do. Workforce shortages is something that is near and dear to my heart. Although many rural facilities are staffed by family docs like me, maybe you've heard family doc, you've heard family physician, FMOB. I'm an FMOB, which means family medicine that does obstetrics. That means that I, deliver babies, I do C-sections, I do all of that, and that is an important factor in a lot of these rural facilities. Per the NRHA, which is the National Rural Health Association, there are only 39.8 PCPs per 100,000 rural residents. Compare that to urban residents in the same study, 53.3 PCPs per 100,000 urban residents. So even in our rural settings, we don't have enough primary care, which I don't think is new to anybody here. When rural hospitals close, family docs just go back to their outpatient setting and they do what they can. But when family docs leave a facility, a rural facility, that's often when the rural facility will close. So just to toot our own horn, family docs important in those rural facilities. So the IHI also lists other challenges like blood bank, other low resources, low revenue for those hospitals with those low volumes, and lots of other issues. But to address these rural challenges in Texas, our TCHMB has joined forces with our perinatal care regions, or our PCRs, in an alliance, which has been a wonderful thing to watch come together. Representatives from DSHS also serve on the TCHMB board, as you heard from Dr. Spear yesterday. The state also receives input on these and other issues from the Perinatal Advisory Council, or the PAC, and that is a council that I chair. The PAC was established in 2013 by House Bill 15 and was charged with providing clinical recommendations to the state, who then folded them into what is now considered the neonatal and maternal care rules, which are used for official designation. Locally, for me, though, our facilities, as I mentioned, are level 2s. We have many quality improvement projects going on in both of those facilities. In the neonatal world, keep in mind that these have been around a little bit longer than the maternal world because of the designation process and trying to make sure that we standardize that care. We have some such things as the 1-hour admission goal, which means that we want to get the IV established, we want to get the umbilical line, we want to get the x-ray, the antibiotics infusing, all within that first hour of admission for our neonatals, or our neonates. We have hand hygiene, which is tracked and trended, and that's throughout the hospitals. We have medication labels with the patient ID, making sure that that matches up on a regular basis, but also that the Mother's Express breast milk is tracked and trended. We also have simulations. We have dystocia drills, dystocia recovery and resuscitation when it comes to the newborn, tiny baby drills. And then on the maternal side, many of those projects, there we go, are centered around the AIM bundles, the Alliance for Innovation on Maternal Health, including the maternal early warnings signs for hypertension and sepsis, maternal hemorrhage. We do risk assessment initiatives. We have a QBL initiative where we're measuring for now and trying to get everybody on board with that, and eventually we'll be tracking and trending and reporting that. And then, of course, the massive transfusion protocols at both facilities. We're also tracking decision to incision time for C-sections and the provider response times for both urgent and emergent requests. And then also we have simulation drills on the maternal side, including for hemorrhage and for dystocia. But each hospital is also supported by their hospital system, a level 3 or level 4, with drill support and best practices, and that has just been phenomenal. That's the way that sitting in the Perinatal Advisory Council, when we were first envisioning this, we really wanted that approach where we had those facilities that have the resources being able to outreach to the facilities that might be struggling with some of those resources. And we see that in real time now. We see it really happening, which is wonderful. In some of our rural facilities in Texas, we find similar initiatives. So not now talking about my facilities, but in other places. In one, we have a safe sleep initiative. I think we heard about some of that yesterday. We have maternal depression screenings, working to expand the referral networks, but also the action plans that we can do with that maternal depression and mental health. Disaster planning, with regional pediatric emergency and mass surge simulations. In another region, we find temperature standardization project. In over 150,000 births, they sought to first document and then improve hypothermia and hyperthermia. The same region has another project on neonatal hypoglycemia and uses telemedicine to collaborate with a level 4 facility for improved care, so just like I mentioned. So these are some of the QI projects in Texas and how our more rural facilities are elevating the quality of care that they provide. But to speak about what's going on in other states, I'll turn the microphone over to Dr. McKee.
So my name is Kim McCam. I'm a little intimidated here because everything is better and bigger in Texas, right? So I'm from South Dakota. I'm a native of the Black Hills. Grew up in a little town of about 5,000 people and went to med school in South Dakota. Did residency down at the University of Kansas in Wichita, where there are many babies. And they serve a large rural population as well. And the interesting thing about working in Wichita is that on Friday afternoons we would have a lot of patients transported into our maternal fetal medicine services, and our perception of those transports was that they were unnecessary, that we were being dumped on, and that really those places shouldn't be practicing obstetrics in the first place. We also had quite a contentious relationship with our family medicine colleagues, believing that, and I did residency in 2000, so forgive my ignorance for those family practice doctors. I've come full circle and am back wholeheartedly supporting the specialty and delivery, so please don't let me get ahead of myself. But there was a real bias against the role that family physicians could play in the outcomes of moms. And as I've, through the last 15, 20 years of my career of delivering babies, I've had to reassess my thoughts on that. Right after residency, I served in a small hospital system in Richland, Washington for 2 years, where we were sort of a level 2 facility. We did a couple hundred deliveries a month, high acuity, and then when I was trying to transport a patient to Spokane, I started getting pushback. It was a 26-weeker, maybe our NICU could take it, and the doctor said to me, if you can't handle this, you really ought not to be practicing medicine. And that was a real turning point in what I decided I want. So I hightailed my back to our tertiary care center in Sioux Falls, where I've practiced since 2006. And in 2015, I became the clinical vice president of the OB service line. And at the time, our health system didn't really know what that meant. And I'd like to think that we've kind of created it on our own. If you could pull up my slides. Great. And then do I have a clicky guy here? You're going to be my clicky guy. Okay. Is this my click? Oh, okay. I'm a Gen Xer, so all you millennials in the audience, forgive me. Okay. So Avera Health System, I work for nuns, and no matter what you think about Catholic health systems, there are some really good things about working for nuns. Number one, their mission is outreach to the marginalized. And when our health system started over 100 years ago, the way that it started, so the story goes, is they put an advertisement in a paper in Aberdeen, South Dakota, to a convent in Ireland stating, if you would like certainly a terrible death, cold winters, and starvation, please come and serve the marginalized in rural South Dakota, right? And so here we are 100 years later. So when I talk to people in Texas, I think it's really interesting, and actually in other areas too, because I hear a lot of things around, well, they don't take the Medicaid population. Well, the sisters would have me by my ears dragging me down the hallway if that ever came out of my mouth. So some of the things that our health systems have done is, we don't really have a choice in our payer source. And I didn't really intend to talk about payer source other than I think that Centers for Medicare and Medicaid are sniffing around this bundled concept of obstetrical care, and it's making me a little nervous because one of the big issues with rural is that we serve a large Medicaid population, and in my state, in South Dakota in particular, we also serve Indian Health Services and our reservation patients as well. And so, as we all know, they're not great payers, and when the government starts sniffing around and saying, well, maybe we ought to do things to cut services, rural facilities are going to be the first ones to suffer. Our rural hospitals, I have actually, we don't do levels of maternal care in South Dakota. We have used that framework within my health system to do our work around what do you deliver, what resources do you need, and what resources are possible. So I have a tertiary care center that would be a level 3 or 4 depending on the day and who's in the hospital. We have 5 level 2 facilities that do between 400 and 500 deliveries a year. And then I have 10 level 1 hospitals, soon to add 2 more that do less than 100 deliveries a year. And when I have people come to tour my health system, 6 years ago they were saying things like, you need to shut those small facilities down. But if you look at South Dakota, there you can see our capital, Pierre, South Dakota. You guys would call it Pierre, but we don't know how to say it, so we say Pierre. Pierre, South Dakota, they are south of the Cheyenne Indian Reservation. They are north of Rosebud and Lower Brule, and they do around 500 deliveries a year. They have a very high acuity population, and they are 3 hours from anywhere. If they want platelets in their facility, they call the Highway Patrol and Rapid City Regional Hospital on the other side of the state, and then they send a Highway Patrol from Pierre. The two meet on Highway 34, and they hand off the platelets, and they take it back to Pierre. How many of you, small facility, who's from a small facility in this room? Raise your hand. Only one? Oh, okay, lots, okay. So when we start talking about maternal levels of care, and our government is our state government's kind of interested in exploring this, one of the things that always comes up is massive transfusion protocol, and you gotta have platelets. Platelets last like last not more than a week on the shelf. You can't have platelets in an MTP in a small facility. You just can't. It's nearly impossible. So these are the things that we're talking about in our system. So again, we do actually this number 6,700 births per year. The ACA birth control thing is working really well in South Dakota. So we're actually at about 6,000 births a year in our system. I want to talk a little bit about our connectivity. We just got an award, and I don't know if these mean anything, but it was kind of interesting. We're one of the most connected health systems in the United States for a variety of reasons. We use something called PeriWatch, fetal monitoring. The reason that that's important is for our small facilities, it has some artificial intelligence attached to it. It does not determine when you should do a C-section, but for people who have lower volumes, it is quite helpful in interpreting fetal heart rate. We have 80 delivering physicians, including OBGYNs. We have a couple of MFMs that are usually just more consultative than anything. And then we are mostly upheld by our family practice physicians who do surgical deliveries as well. Our MFMs do asynchronous telemedicine. We don't have the bodies to do a synchronous telemedicine process yet, but that's quite helpful. And when we talk about rural in South Dakota, ACOG says if you're more than 30 minutes away from a delivery center that that's too far. I don't know, I kind of feel like 30 minutes is not that big of a deal. 60 minutes in February, like last week, was a really big deal when it was snowing. So if there's any Minnesota peeps in the room here, they know what that we're talking about. So one of the things that when I took over so what I want to talk to you today is about some of the quality improvement stuff that we've done over the last 5 years, and it really falls into 3 buckets. One is culture, other is resources, set 2 is resources and levers, and 3 is risk out and risk up, okay? So when I became the service line coordinator person, I went around, we hired someone to come in and do a culture sort of team training, team steps in all our facilities. And I don't know why we picked that other than I had done it in my hospital like the 8 years previous, and it was something that really made a difference around the practice of medicine. So when we talk about team training and team steps, nurses and doctors are trained very differently. Nurses will call a doctor and they do these leading conversations around Do you think that, what do you think about, and you know how, does everybody do SBAR training here? I call it SBA because everybody forgets the request. So what's the request? And then physicians, we're just like diagnose and treat. Like, just give me the facts, I'll make a decision. And when you have those two people working together, it's very easy to see that communication becomes a problem. And so when we went around to these small hospitals and we did kind of a needs assessment, my standard question was, what keeps you up at 2 in the morning in a small hospital? And you can about imagine that it's the same things that keep me up in a large hospital. It's bleeding, it's I don't have enough staff, but those kind of things mean more in a rural hospital because their bench is not very deep. There just aren't enough bodies to come in. And so when we did a needs assessment, I worked with a physician out of Beth Israel Deaconess named Susan Mann, and she runs something called the Qualbridge Institute that really goes around and teaches team steps. And when we first started going into hospitals, her thing was, well, maybe you should shut some of these things down. And obviously, I said, we can't even put that on the table. We just want to understand what they need for resources. So there were some things that were really kind of stand out. Number one, blood bank wasn't standardized. Number two, there needed to be some definition of gestational age around sort of like on the baby side, like there wasn't kind of a standard, like this is what we can do in our facility. And I don't know that there needs to be, other than it has to be within what your pediatricians and family med docs can handle. The blood bank processes were not super streamlined. They didn't have an MTP at all, or the equivalent of an MTP. So it gave us kind of a framework on where do we even start. We went into these facilities, and every 2 years we do a team training and simulation event. We have just done it now for our 3rd time. But what was clear about the training that needed to take place is, number one, it needed to be specific for the facility, and number two, it was really hard for staff to take time off for them to divert these resources, even for 2 hours to get the training done. So when you've got, in a critical access hospital, it has to be less than 25 beds. You all probably know that, less than 25 beds. And then the nurse staffing during the day, usually those beds, they may have 7 to 12 beds full, sometimes 5 to 7. And so the nursing ratio, if you're doing a 4-to-1 nursing ratio, that'll mean 2 to 3 nurses in the hospital, with maybe another on backup. The other thing that's interesting about small facilities is that all nurses are cross-trained. So meaning they do obstetrics, and then they also do med-surg and all of those other things. So you may be a nurse that they may have a bench of, say, 15 nurses to cover their facilities, and if they do 50 deliveries, those nurses may only participate in 5 to 7 deliveries a year. So you can start to see that quality can really become an issue. So the question we asked ourselves was not how do we educate people, because education is not sustainable. What we took the approach of is how do we engineer success? We spend a lot of time in this country focusing on medical error, and I think it's good to do, but we don't spend a lot of time engineering success and engineering a pathway that makes it easy for people to do the right thing. So when we talked about that, we said, how do we resource assess people that allows them to do this in a way that just is intuitive? After Susan came to my hospital system and saw the work we were doing, she said, nobody's doing this. And I still don't know that that's true. I know that we have done this work really well and couldn't have done it without my partners. I don't have a lot of fancy data, guys. And the gentleman from California who was talking about the burden of collecting data on the system is really, really, really difficult. But we're in that framework right now. But one of the things that was really clear in the rural facilities is this idea of, when I call a tertiary care center and ask for help, please believe me. This patient has outstripped our resources. Please believe me. And that's what the Maternal Health Compact was about, is as tertiary care centers, what can we do to support rural? Make it easy. Okay, what do you need? What do you need? How can I help? And we do this to varying degrees of, this is our ability to accept transports in any system is always going to be based on who's answering the phone, what information you're giving, and obviously if you're burned out or whatever. And I will tell you, we do this well at times and not well at other times. But in general, if someone's asking for help, that's kind of our culture. So between our team training and then the idea of if someone asks for help, you give it to them. And then the third thing around culture is if you're not in the house, you're not the captain of the ship. Okay, so if you're a physician in an outlying facility and you're at home in bed and the nurse is calling you to say your 19-year-old patient is bleeding and they're just giving you an order for meds and meds and meds, you're not the captain of the ship. You need to come in. And that's made a big difference. So when I have to do quality review, thanks. So when we do quality review in these facilities, that's one thing they ask was, who was the captain of the ship? In your debriefs, who was the captain of the ship? We told another story after this was in 2017, after a lot of the data was coming out about our maternal mortality. And it was, what can we do now? And that's what I want to talk about, is what we did now. CMS quality metrics have been a really important part of sort of moving the meter on quality, obviously. Early elective delivery was something that we had a lot of trouble with. South Dakota is the winner of a pretty high infant mortality rate. And I'm not gonna lie, we've got racial disparities, we've got rural disparities, we've got that stuff that we are working on, and still, like you all, are struggling to figure out how to do that better. But the early elective delivery was something that we did early on, and the way that we made it successful was that we put a scheduling process in place that did not allow for facilities to enter a delivery. There was kind of a hard stop on gestational age. And then there had to be a justification based on the CMS rules. So that was one of our ones that, again, we set people up for success. And physicians kind of grumbled about it, but in the end, I think people mostly came around. Some of these have been retired. But here's the thing that you might not know, or at least people in tertiary care facilities or level 3s and 4s might know. Not all facilities are Joint Commission accredited, and they don't need to be. Critical access hospitals have a different accreditation. So these aren't great levers all the time. When you're talking about a small facility about early elective delivery, I've got 10 hospitals where doesn't even register. Fortunately, most of them are family practice doctors and they're rule followers, so they don't violate any of that, right? So again, we took the approach of how do we implement a standard process around some of these measures, because our goal is not to just do things for Joint Commission or a regulation. Our goal is that you would walk into every facility in the Avera footprint and there would be a standard of care. And so what we did is we had to find where the levers were. About 4 years ago, we have used the National Perinatal Information Center for about 10 years at our larger hospital, and have not made the decision to do that for a small hospital for a couple of reasons. Number one, they can't afford it. And number two, the data piece, there has to be a data person in the facility to enter that data to make the feed work. See, I'm a Gen X, but I do know that. It's not automated, right? So the data collection became something that we thought, well, how do we do this within our own system? For those of you who are on Meditech and Meditech haters, or those of you who are on Epic, and Epic creates unicorns and amputates arms, it's gonna become a doctor any day now. We can't afford Epic. It's $250 million to serve our health system, and the sisters are like, no, that's for our patients. We're gonna do Meditech. And so I happen to be an identical twin who's a human factors engineer and a physician who has helped engineer a medical record so that we actually don't get a lot of complaints about it. And the cool thing is, by engineering our medical record, we can get actually a lot of standardized data on it, because I know where all the discrete data points live. Like on our delivery summary, we always put in delivery time so we can do stage 1, 2, and 3, and we get a feed from PeriWatch that goes into our delivery summary. We also do qualitative blood loss that the nurses enter that pulls into the physician documentation. We have a query for postpartum hemorrhage, yes or no, because on the coding side, uterine atony, a lot of the coders will pick up atony as a hemorrhage, and it's not a hemorrhage. And so we have postpartum hemorrhage, yes or no, if you've also documented some of that. So coding consistency has been really key. And so we have a database that's sort of based on the NPIC Adverse Outcome Index and the usual things that you would think of in addition to some other things. Transfers are really hard to track, but I think we figured that out as well, because in rural facilities, maternal death doesn't happen. And fortunately, we haven't, knock wood, I'm superstitious, but I'm gonna be on call tomorrow, so. We haven't had a maternal death in our system for a really long time, certainly severe maternal morbidity, but transfers are an important sort of marker of how well is a rural facility risking their patient out or taking care of them and stopping that severe maternal morbidity before it gets too bad. So again, we follow hemorrhage, unplanned ICU admission, say in my hospital, hypertensive crisis not responsive to meds, sepsis, and then of course, transfer to a higher level of care. I wanna just talk for a minute about implementing the AIM safety bundles, because I think that it's really hard for small facilities when you start reading about the CMQCC guidelines and you get to the point on the postpartum hemorrhage where you have to have immediate access to an interventional radiologist, you just kind of stop, right? Like, how the heck am I gonna do that? Who has an interventional radiologist in their small hospital? Like, nobody does, right? So what we've done is, again, said, okay, what's an AIM safety bundle in a small facility based on the resources that they have? What I've noticed about safety bundles, and I know you guys work within the level of the maternal level of care framework, and if you can get platelets into every level 2 facility, you need to let me know how to do that, because I haven't done that yet. The blood banks are tight on the platelets. So if you need an MTP in your hospital that also has platelets, you're gonna have a whole bunch of level 1 facilities. I'm an outsider, so can I be a little bit, I can be a little bit sassy about it, I think. But so blood bank was one of the first places that we looked and did resource assessment, and what we did find is that facilities did not have FFP or cryo. We also found that facilities didn't often use FFP, and they used water baths to warm them up. Do you guys know how long it takes to thaw platelets? Who knows that?
I do.
You do. What is it?
A long time.
A long time. It does. And you can't put them in your armpit, right? You can't. And so when you're combining a water bath that can grow Pseudomonas and has to have all these quality checks, we had people that were stuck in a hemorrhage where they needed FFP and they just couldn't get it. So we did a system-wide project with our blood bank who found a little microwave oven guy that was around $4,999 because we don't have to do capital requests above $5,000 so that these facilities, see? Yeah. I'm a little irreverent and I push the rules. And so they have these little microwaves now and it takes them 20 minutes to thaw FFP, which is really great. So we did make that requirement. You gotta have FFP in your facility if you're gonna deliver babies. The other thing is that meds are really important. And when the labetalol shortage hit a couple years ago, we did a lot of like preloaded 20 milligram syringes, and small facilities couldn't even get through the labetalol algorithm because we just didn't. So they got the big bottles, but even then there was room for med errors. So they switched and now did, the hydralazine. They would use hydralazine as first line. And so those are the things that we're talking about in terms of resource assessment. And I really want to press on you small facilities. I don't think you have to do everything the way that a tertiary care center does it. That's not what we're trying to do. In our facilities, we're not trying to make a mini tertiary care centers. What we're trying to do is say, what are your resources? How well are they organized? And then how do you keep stuff from happening or going downhill when it's happening? One of the other things about pharmacy needs is how many of you know what it takes to have a medication approved in your own facility? Because tertiary care center, you like just order it, right? You probably know.
Yeah, I know.
Yeah.
It's P&T committee.
Yeah, P&T committee, and And then when you
And then
order
the
it,
financial person.
and the financial person, and so there's this whole like thing to get even TXA into these facilities. So what we did is we said, let's do a gap analysis and see where the medications are living and see what people need. So now everybody has TXA. And then at night, because when you order a medication, it has to be verified by a pharmacist, we have emergency med release packs that are in like literally a tackle box from like, Shields or something where people can pull the meds and get it quickly. So, and then the other thing that's really interesting is that A1 says you gotta have 2 nurses in a delivery. In you small facilities, how easy is that to get 2 nurses in a delivery 100% of the time? It sometimes is nearly impossible. And so again, it's one of those regulatory things that if my physician from Parkston, South Dakota gets sued and they pull in A1 guidelines and say, this is what you gotta do and you didn't do that, and now you're on the hook for the medical, legal, and 21 years of liability, that gets really rough. And so we've said, yeah, it'd be great to have 2 people, but you have to have a list of the things that are the absolute must. So find, again, where's that lever, where's that resource? If you're worried about a shoulder dystocia, you're having a team meeting and you're saying, okay, when we get to delivery of the Vertex, we're gonna have 2 people, maybe 3 in there, so that you're telescoping these things. One of the great things that my twin did, I'll give her credit, you can just pretend I'm her right now. They made a system governance for all of our hospitals that you only get the order sets that we give you, and we have a physician review team that manages those. So for you Epic hospitals, you can do whatever you want, right? In my Meditech hospitals, I cannot. And so if a physician wants a change in protocol, they have a process they have to go through. Now, there are some things that slow down and you wish it was faster, but in terms of the standard stuff that we do to treat hypertension, bleeding, VTE prophylaxis, that's all in our order set. And then what's really cool is like on our hypertension order sets, the nurses on their end get their protocol that's pulled up so that they just are looking and saying, okay, so I'm gonna recheck my blood pressure in 15 minutes. They can set an alert that'll send it back to them so that we're hopefully meeting our severe hypertension measure. We have standardized carts and medications for workflow. We've combined our hypertension set with our hemorrhage set so that those meds are together. And there are a number of our facilities that actually keep the refrigerated meds in the delivery suite in a little mini fridge. You gotta be careful of the mini fridge because they don't keep the temperature quite right. But sometimes in a small facility, there's only one Pyxis and it's down by the ER, so you don't wanna have people running back and forth. Okay. And then the last thing I'll kind of harp on is, again, blood bank. Platelets are precious. They're hard to get. They expire. So we've kind of said, you know what? In a small facility, your MTP doesn't have to have platelets. And we're just about to go live with a maternal level of care specific MTP for every facility. Are any of you guys doing whole blood yet? Yeah, so we're talking about that at our tertiary care center. I can tell you that's probably not gonna happen in our smaller facilities. And let's see. Okay. The last thing that we did is risk out and risk up. So this is a picture of the interstate going from Mitchell, South Dakota to Sioux Falls in February last year. Isn't that nice? My husband was driving and I almost killed him. He's from Florida, it wasn't good. Yeah. So again, 5 years ago when I took over, one of the things we said is like we gotta do a risk assessment on moms, and I was just looking through your maternal levels of care, and you talked about moderate risk patients, and I couldn't get to the link that said what that was. And we haven't been as prescriptive as that. I will tell you that we picked the big things where we were seeing transports come in. Morbid obesity is South Dakotans, we like potatoes and pancakes, I like to say. So, diabetes and hypertension and obesity does very well. And so for anybody who's a BMI of 50 or higher, or if the facility is worried about it, they come to the tertiary care center, and we actually have a way to a teleconsultation service to get those patients in. We do most of the VBACs. And then our type 2 diabetics, we do something called shared care, either with the local facility or with maternal fetal medicine and our FP docs, so that those patients are co-managed by that team of people. Again, it's very, very tempting to say, these patients can only be taken care of by midwives, and these only by FP, but that's not practical because that makes patients drive. And one of the things that we know in rural is that as healthcare costs go up, and there was just a really nice article in Health Affairs around the out-of-pocket costs that moms experience with their prenatal care, one of which is time off of work and gas. When I have a rural patient that has to drive to Sioux Falls to receive their care, that's a whole day off of work. It eats into their FMLA, it's gas, and in rural, people tend to be poorer as well. So it's a nice, when we've been able to sort of breach that gap with teleconsultation, telemedicine, we do that. So the consults guide's been really great. It's almost been too great because there are some people that risk themselves out too well, and we're like, no, you really probably could keep this patient. So I can tell you where we think we're going for the future is around having a telemedicine footprint. The thing that I didn't mention is that Avera has one of the largest footprints of telemedicine in the United States. We cover around 20 states. We even have some hospitals in South Texas that our emergency docs and eCare Pharmacy, eCare ICU are helping cover and shore up costs, and we believe that same technology can be used in the delivery suite. There's a lot of focus right now on the prenatal portion of care, which is very important, and on getting resources for drug addiction, and we have really big problems with that in South Dakota. That is also important. And we are working on this intrapartum event, and my belief is that as we start, that we cannot forget about the importance of the intrapartum event as it relates to maternal outcomes. And so all the funding right now is really focused on the pre and post delivery, again, really, really important. I'm interested as healthcare policy and as grants start to come out, I'm interested as to how we're gonna be able to connect to each other in this intrapartum episode of care. So, so that's kind of where my head's at in terms of how we're gonna, the next steps in our system to shore us up through our very well-connected telemedicine. So that's it.
Thank you. All right, questions, comments? Don't be shy.
Hi, I'm Teresa Morris. I'm a professor of sociology at Texas A&M University. And I just would like to first thank you both and also to say the last panel was fantastic. And just a nod out to Dr. McKay, you mentioned that you liked Dr. Prophet's data and research that he had. And just to say, and part of his data was qualitative data where he had interviewed families. And to say that I know that with the pressure for measurable outcomes, that's really hard. To get done in hospitals, and most physicians and physician researchers aren't trained on qualitative data analysis, but social scientists are. So I would say reach out to academics in your state. I do qualitative research, and many of us are interested and would be interested in helping hospitals collect that type of data and analyze it, and I'm fairly certain Dr. Prophet has worked with social scientists to do that. So anyway, just to say that there are available resources for you.
If you'll come to South Dakota, I got a job for you, maybe.
But can you pay her?
Yeah, well, I mean, that's the deal, right? Like, we have qualitative people, but it's hard to find the grant. We have to do it usually through grant funding or on my own, which I'm just not that smart, but.
Other questions and comments? Now, an anecdote.
Thank you both so much for coming. I'm Dr. Jennifer Bump. I'm an OB-GYN in Houston, but I gave birth to my last two children in New Braunfels, Texas, so I'm very well of your micro-urban environment. And I guess just as an anecdote for those of us who practice in the medical center or other large medical places, it's sometimes hard for us to understand what it's like to work in places that maybe don't have as many resources or just as much volume for everybody to see every anomaly. I practice at Texas Children's Hospital, so we obviously are a huge referral center. We see every type of pediatric fetal anomaly that you can imagine. But when I gave birth to my child at New Braunfels, my first one that I gave birth there, they had unexpected cleft lip and palate. Nobody there knew how to feed my baby. And everyone said, okay, well, you got to keep breastfeeding, because that was back in the day that everybody, a huge breastfeeding champion. And, I'm not faulting anybody, because I certainly wouldn't be able to figure it out with a low volume either. So my child lost a tremendous amount of weight because couldn't eat. And it wasn't until one of the nurses, the charge nurse came on, who practiced in San Antonio on a regular basis, came and said, oh no, this cleft baby cannot breastfeed. You're gonna have to give this baby something, because this baby can't create enough suction to breastfeed. So, there's just one example. I was not a physician back then. I actually worked as an accountant for 20 years before I went to med school, so I greatly understand your pressure from a financial aspect as well. But I just want to say thank you so much for both of you for bringing it to our attention, and thank you so much for working in rural in settings, because my husband and I have frequently talked about retiring to the country, or even just finishing, moving my practice once the kids are all out of school and, all of that. And I'm like, honey, you realize if I live in New Braunfels that I'm going to be on call every night, So thank you both so much for being willing to do so.
Thank you. To make a comment, can you hear from this mic? Is this on? No, this is not. Oh,
Yep.
There I am. Thank you very much, Dr. Bump, for commenting on that. And I think that really highlights that need that we are moving in the state of Texas to make it so that all of our facilities have those resources, maybe not with the person that's physically there, but to be able to, with telemedicine and with that benefit, be able to have that level of expertise available at all times.
Yeah, I would say the same thing, that, we're working on an e-care NICU pathway right now, and which is pretty cool, that you can press a red button on a wall and get an expert. And our hope is that technology is going to keep people in their own because that's not something that you would actually need to transport in necessarily. It's something that you just have someone look at them and be like, oh, just use this bottle, and that's it. So I'm looking forward to seeing how that moves the meter on some of our data. I don't want you to think we don't follow zero data. We do follow some that's easy to get at, but yeah, so those are the things we're trying to prevent. And in this day and age, there's just not a great reason why we're not connected. South Dakota's done a lot of work around Wi-Fi, and the one thing I would say is that Wi-Fi access is now a social determinant of health. You cannot exist in the United States today without having access to the internet. And so South Dakota's done a lot of work around connectivity. I don't know where Texas lands with that, but it makes it easy when we start thinking about innovative ways to get people to connect. In South Dakota, we have it a little easier.
I just wanted to give a plug to the midwives. We work with like 5 midwives. One of them was getting their doctorate, and this was, 4, 5, 6 years ago. And so we were talking about hemorrhage and what we could do to improve, and we're like, it'd be great to have simulation. So that's what she did for her doctorate. And so she set up some very good simulations for us. Mm-hmm. So if you can get some midwives to work with you, especially in the rural setting, which is where we work in Kerrville, they've been great. They come in with energy. They come in with that nursing background. We recently did a spinning babies because one of the midwives came and she's like, let's set this up. How can we reduce our primary C-section rate? So I really want to encourage practices to adopt midwives into their practice.
I love my midwives at my hospital. We can't get anybody to want to go live in rural is the problem. If you have midwives that'll come and live in a small town and be on call every day, I'll give you my card when yeah.
You need them in sets of 3 so they can have,
but I
have
would
a
also,
life as well.
I would echo that. A lot of times the response that we hear is, well, just get a midwife. Get a midwife, get a nurse practitioner, get and whatever that level of expertise is, just get them to go out. Well, they don't want to go just as much as the other people, you know, so it's a unicorn. It's something. It's a unique opportunity to find somebody. And Kerrville is an excellent example of these certified nurse midwives that are phenomenally trained. They work well in the hospital system. They work well with physicians, whether family docs or obstetricians, and they work well with the right acuity of patients. So we can all work together to bring that care elevated, and that's why I mentioned earlier that in the rural facilities, just as much as the urban facilities, we need to make sure that we are using every bit of our expertise to have people function at that maximum level of their knowledge and expertise.
Sure. Jennifer Lidke, I practice family medicine OB in Sweetwater. And two comments. One, I completely echo the sentiment that just last week I had a 32-weeker in preterm labor who I had tried 2 tocolytics on, was on magnesium drip, and I called my local referral center to transfer this patient as we only had 2 nurses on the floor coming up for night shift. And I met with feedback that, oh no, you just need to keep increasing the mag. And I had 2 laboring patients as well. And so I had to actually escalate and go up the rung to the next doctor on call. And that's here in Texas where we think that access should be freely given. And I said, look, I can't keep this patient here. I don't have the staffing. I don't have anything like that. And so that is a real problem. The second thing I'd like to just bring up is as we go into the next biennium, the Medicaid 1115 waiver that some of you may or may not know, rural facilities are reliant on that waiver, and I know there's a transition, and I know a lot of people are saying that, oh, don't worry, the legislator will just push it through. But I worry because our facility cannot function without that, and they're gonna have to make cuts. And labor and delivery is the place where they're gonna cut most likely, because it's the place that is Medicaid funded. And I just know that there's a lot of people in the room that work with legislators. There's a lot of grassroots legislation going on, and that's something that I think we really need to look at, because my mamas don't want to drive the extra hour to get OB care. They're not going to, so then our mortality and morbidity rates are going to go up. And so just as a food for thought out there.
Joe Garcia-Prats, Bentop General Hospital, Houston. One of the biggest challenges in all of our institution is how siloed we are. I was very fortunate in 2009 to get introduced to Team Steps, and it has radically changed our ability to communicate and have great teamwork between our obstetrical services, neo, anesthesiology, midwives, et cetera. Would you comment a little bit more, Dr. McKay, about Team Steps and how it's affected your system?
Yeah, it's like my favorite thing, because not everybody knows how to communicate, and they get stressed about things, and so being able to level set on communication, not just SBAR, but formulating things around situational awareness. So we talk about board reports. Many of you do board reports, but we have a multidisciplinary board report at my hospital. And in our critical access hospitals and regional facilities, one of the things that we tried to do with a board report was just to say, just do it for obstetrics. Well, they need to do it actually for their entire hospital when you've got 5 to 7 beds. So our small facilities were like, okay, this might be a game changer for us to understand, if you've got, so for example, Pierre is such a great little hospital. They have 4 ORs. They have, their labor and delivery is up 2 floors, so when they do an emergency section, they have to go down 2 floors down an elevator, and they have a key that they need for the elevator to make it skip floors. And when I went to Pierre on my first site visit, they said, we need an OR on labor and delivery, which most of us would be like, yeah, except for that's like $1 million or more. And I was able to say, okay, well, tell me your process to get to the OR, and it was about a 7-minute bed ride, so they practiced that, and I said, how often when you get to the OR is your emergency team there? And they said 0% of the time. So I said, well, we can't build you an OR. If you get to the OR first, then it just doesn't matter, right? So Team Steps is, yes, it's about communication, but it's also about resource assessment. And so for peer, what it took for them is, what's the acuity of your patient that you're laboring right now? Does the anesthesia team, they actually have a house that they purchased across the street from the hospital, because some of the anesthetists up there have ranches too, and they live about 14, 15 miles out of town. So, if the patient's a high acuity patient, the anesthesiologist or the anesthetist will stay at that house, and, they have a really organized way of making phone calls and paging people, and so again, it was Team Steps that really was the pathway for them to understand how to do their job better. And they haven't asked me for an OR since, because now they can get to their OR in 3 minutes, and their team's there. And then the other thing is, if you're not the captain of the ship, or you're not the captain of the ship if you're not in the house. And so at 2 a.m., when a nurse is doing SBAR with our physicians, the first thing they do is say, I need you to come in, here's the situation, so that they're doing that request up front. And so those are just two sort of anecdotes of how that strategy has really helped us with our own culture and how we do business at Avera.
One comment, rural hospitals are not necessarily in rural areas. Small hospitals in urban areas have exactly the same kind of problems that rural hospitals have, so far as resources, protocols, implementation, et cetera. So those of us who have in the past or in the future or in the present are in these types of hospitals, we ought to look in the mirror and make sure that we're not being hypocritical.
So I would just say it's urban adjacent. Katie Cozumel is out of the University of Minnesota, calls it urban adjacent, rural, and urban. And the urban adjacent communities have very similar issues.
Okay. Any further comments?
I would just like to highlight the need for that collaboration, that really in this day and age, when we do have good Wi-Fi, or maybe intermittent sparse Wi-Fi, but that connectability, we really need to maximize that. In New Braunfels, I regularly use my MFMs who are in surrounding big cities, and my patients are so gracious. They don't have to drive that far. They don't have the ability to drive that far. I have some patients that come from very small towns outside of our micro-urban center for their care, because they recognize the quality of care that they're getting in this micro-urban facility is fantastic. And so it's something that we can really elevate that care throughout Texas, and I'm just happy to be a part of this day and age.
I'll tell you one story, because I'm a talker. We had, about 7 years ago, I got a phone call from a physician who had delivered an 18-year-old low-risk patient in his small facility, and he said, I think I've got a uterine inversion. So we FaceTimed, took the patient to the OR, we talked his team through the anesthesia and how to reduce it, and at the same time we deployed an emergency team with blood product to go pick that patient up, and her EBL was around 700. And she got discharged 2 days later. So that is the potential of this technology to help with maternal mortality and morbidity.
Okay. All right. Okay, we have